right, so I'm going to take the first question, and thank you. That was wonderful, Sylvie. So you've got the recommendation from IVHEM for universal screening for adults, correct?
Yes.
So I think in the U.S. we're looking at that as well, and we know that in most countries we're not going to get to elimination without something like universal screening. So what is it that the Autorité de Santé is considering at this point, and what do you think will make them move in that direction?
In fact, I didn't show you, but maybe during the sensitivity analysis of my model, there was another concurrent strategy that was also cost-effective. It was the one that would screen all adults 40 to 80. So I don't think that is really the problem, but I think, of course, the cost could be the problem for the Autorité de la Santé to direct the authorities on this way. But we are optimistic. Yeah.
Good. Well, hopefully you'll show us the way again.
It's in a good way.
Jordan.
Thanks, Sylvie. Very nice work, as you've been doing for years. A couple of questions. One is, when you mentioned at the end the recommendation to do the seroprevalence surveys, how frequently do those need to be updated? So in terms of monitoring your progress, how do you have to do them every year, every 2 years, every 5 years? What is the frequency of
the seroprevalence
surveys that
it's very, very, very expensive.
I know. That's why I'm asking you why it's so. How frequently?
National seroprevalence surveys. We could not do another one in France, for example. 10 years was, I think, a good timing. As you can see, we had a lot of actions between the two seroprevalence surveys, and the second one could also evaluate what happened during both estimates.
The time.
What happens if the national plans were efficient. 10 years, I think, was fine, but we could not have a third one. That's sure.
Okay.
Can I make a quick comment on
Sero
survey? It is indeed very expensive. So what we're trying to recommend, particularly for low and middle income countries, is try to integrate with other surveys that are going on. And when I go to country and when you start asking around, there's almost one population-based survey done every year. One is for hypertension, one for diabetes, one for TB incidence, one for HIV impact monitoring. So I think it's about piggybacking on other surveys that are going on and making it happen with a small incremental cost. In Bhutan, we did it through a measles and rubella seroimmunity survey, and we just had to pay another $25,000, and the bulk of the costs were covered by the measles rubella survey.
So that was actually one of the questions I was going to ask you, is whether you piggyback, because to me 10 years actually seems too infrequent to really monitor your progress, but it might work in countries like France, but I think in many countries, especially where the epidemic is changing, like the US as an example, I think you would miss big chunks if you really did it that infrequently. The second question I wanted to ask you was, France has traditionally had this very sort of centralized care where hepatitis care is always delivered by specialists. And I see that the IVHEM has finally said, move it out of specialty, which is a big change for France.
Yes.
And one of the questions that I wanted to know is whether there's a system to monitor treatment. So will you know the number of people that are treated, if people are being treated in all the different centers?
Yes, we know how many people are treated because we have a central system for reimbursement, because treatment are reimbursed.
Okay, so it's through you can still track that.
Yes, we know that. It's a big chance to have this system, and we can trust the all individuals.
The results, because it is a challenge in countries where some people get their drugs through private coverage versus public coverage, is to even find out how many people have been treated per year is not so simple. Right. So it's important. But thanks a lot.
Yeah, Olafsson from Iceland. I have a question for Manal. First of all, I would like to congratulate you on the impressive work that you're doing. I have a question regarding the what proportion of your patient population are people who have history of injecting drugs, and how successful are you to get this patient population tested and linked to care?
Yeah, it's a very small population. The ones who are injecting drug use out of this whole population. But they are linked to care, and we go and target them for testing now. But I would like to tell you that we do not have a needle exchange program in Egypt. And we don't have an oral substitution therapy for intravenous drug users in Egypt. But we're testing them and we're giving them treatment. And we do have clinics particularly dedicated for intravenous drug users. And even now we're going to link the younger population, the adolescents, because the Ministry of Social Solidarity is looking after those people. And we agreed with them that we're going also to link the younger population. We're going to screen them and test them and link them to care.
All right, we've got time for one, maybe two more questions. Margaret.
Manal, just wanting to follow up on that price that you got for PCR testing, because I think most people would be going, how did that happen and how can we get that price? Or even close to that price, particularly resource-limited countries. So can you go over who's the company, how did the negotiations happen, how close do you think other countries can get to that price and that they won't have quite the number of tests going on that you've got?
Well, the company for PCR is Roche. And Roche had an agreement initially, and that was the tricky thing. They had an agreement initially that the testing, because that's what they were going, that was happening initially, get the chemiluminescence and the reflex testing with PCR. And then when we were asked by the minister to advise about the massive scale-up of treatment, I was heading the screening committee and said, this is not doable because we cannot go and get samples for every single person from the population, 45 million in 1 year. This is impossible. And you're going to have complications of drawing blood samples for every single person. So it has to be an RDT. It has to be a finger prick test. So we started negotiating again with Roche because they already, we have agreed as a government, they have agreed previously to get this plus the PCR reflex testing. And they had no choice but bring down the price, and we took some devices for free as well. So we have 55 PCR machines, extra machines than the ones that are, and actually we're moving them from one phase to the other. We're moving the machines to cover also other phases. Because as you've seen, the first phase targeted 17 million and the second 20 million. So the numbers are huge. And we have around 5% positive antibodies, so we need to test all those people. So we have a flow chart that exactly shows which machines to be used every day, which tests, which government, where it goes. So everything is so detailed. We have an executive committee that we're detailing everything. So they had to agree. And I think it's negotiation, it's always volume. And we have the leverage of being one of the biggest countries doing a program like this. And if you contribute to our program, you're going to show the case in other countries and you can use this. So that's a sort of a bargain that we're, I think we've been clever in doing this for the past 10 years and it's working.
Very good. Well, thank you, Manal and Sylvie, for two great presentations.